Hello and welcome back everyone. So this video will mark the beginning of a new series about the emergency medicine. So I'm going to teach the emergency medicine because this is specialty I'm the most passionate about, and I feel like I can provide a lot of value by teaching this. And we will start by explaining the airway management. So the airway management is not well covered in textbooks, and we will try to change this through these videos. Now the airway comes first in resuscitation because remember, we follow the ABCs and the A stands for the airway. Now whatever you do in resuscitation is useless if the airway is blocked. So the airway comes first. And the airway starts from the nasal orifices and ends in the alveoli. So it starts here and ends in the alveoli here. Now in resuscitation, we manage the upper airway. And the upper airway is supraglottic, which is everything above the glottis and also means everything in the neck and above, and not the thoracic part of the airway. So on this picture here, we manage everything supraglottic. So this is the glottis here. So we manage everything supraglottic in resuscitation in the airway management. Now regarding the anatomy of the airway we are dealing with, is start from the nasal cavity here and then into the pharynx and then into the larynx here. We have here the laryngeal opening and the epiglottis and a groove between the epiglottis and the pharynx here, which is called the vallecula, and the trachea. Now let's talk about the characteristics of the normal airway. So for the airway to work normally, it has to be patent, which means open, and it has to be protected by the neurological reflexes like the cuff reflex, which protect the airway from foreign bodies entering the airway. So the cuff reflex expels those foreign bodies out, and also the swallow reflex, which works by swallowing the secretions secreted that would go into the airway if not swallowed and lead to inflammation and obstruction of the airway. Now the airway also has to be maintained, and this means that the airway stays open if the patient position changed or if the time passed. Now again, for the airway to work normally, it has to be patent, protected and maintained. Now let's talk about the maintained airway a little bit more. So in case a patient Glasgow Coma Scale is less than 8, remember the Glasgow Coma Scale is used to assess the consciousness of a patient, and it is not the best scale for calculating the consciousness, but it is the easiest one to apply. So in case the patient Glasgow Coma Scale is less than 8, this means that they have severe depression in consciousness, and this also means that the other brain functions other than consciousness is also severely depressed. Now one of the brain functions is the pharyngeal muscle tone, and the pharyngeal muscle tone in normal persons it's always present. So the pharyngeal muscles are always contracted to some degrees in normal people, and that is achieved by that certain brain neurons is continuously discharging to keep the pharyngeal muscle tone present. Now in case the Glasgow Coma Scale of a patient is less than 8, this means that they have severe depression in consciousness, and also the other brain functions like the pharyngeal muscle tone might be also depressed, and this means that if the patient is lying supine, this will lead to the tongue will prolapse posteriorly and the airway get blocked. That is why if the patient classical coma scale is less than 8, their position have to be on their side to prevent the tongue from prolapsing posteriorly. And for this reason, their airway is not maintained, because for their airway to be maintained, they have to be on a certain position which is lying laterally on their side, and if they lie supine, the tongue will prolapse and block the airway. And their airway is not maintained because remember, for the airway to be maintained, it has to be open if the patient positions change. And in that case, the patient position, if changed, the airway will be blocked. So the airway is not maintained. Now another example on the maintained airway is that in case of angioedema to lips and to the tongue, like the picture you see here, this might happen after some type of allergy reaction, and this means that the airway is not maintained because the airway might get blocked in the future after the time is passing, and that is when the angioedema reaches the pharynx and the larynx. And again, the airway is not maintained in that case because remember, for the airway to be maintained, it has to be open if time passed. And in the case of angioedema, if the time passed, the airway might get blocked. Now a question might pop up to your mind, and that is when to manage the airway, when airway management is needed, and that is if any problem in airway patency or protection or maintenance is present. This will require airway management by creating an artificial airway that has all the characteristics of the normal airway, like the patency, the protection, and the maintenance. And this is called the definitive airway. Now, the definitive airway is a tube that connects the external environment with the trachea and has a cuff inflated below the vocal cords, and the cuff is to prevent the secretions from entering the trachea. Now, some of you might think that the cuff is for securing the airway and preventing it from slipping outside the trachea, but that is false. The cuff is for preventing the secretions from entering the trachea, and to secure the airway and prevent it from slipping, there are some external methods that are used. Now, examples for the definitive airway include the endotracheal tube, and the endotracheal tube is a tube inserted nasally or through the mouth. Nasally is rare, but through the mouth is the most common way to insert it, and it enters the trachea and it has a cuff inflated below the vocal cords. Now, the endotracheal tube achieves the characteristics of the normal airway because it is patent, it is made by relatively hard material resistant to kinking, so it stays open, and it is protected by the cuff that prevents the secretions from entering the trachea, and it is also protected by frequent suctioning, and it is maintained because it is open regardless of time and position of the patient. And on this picture here, you can see the endotracheal tube. Here you can see the cuff of the endotracheal tube, and on this picture you can see it inserted on a patient, and you can see it going through the mouth and into the trachea here. The other example for a definitive airway is the cricothyroidotomy, or what is called the cric. So the cric is done by opening the cricothyroid membrane, which is a membrane between the thyroid cartilage and the cricoid cartilage, and then you go into the trachea, and it also has a cuff inflated below the vocal cords. Now, as you can see on this picture here, here we have the thyroid cartilage, and here we have the cricoid cartilage. And the cric is done in the membrane between these cartilages. It is called the cricothyroid membrane. So the incision is done vertically, and then another incision inside this membrane is done, and then the tube is inserted into the trachea, and then the cuff is inflated. Now for the surface anatomy, I will do it on myself. So as you can see here, we have the thyroid cartilage here, and below the thyroid cartilage, we have the cricoid cartilage, which is this one here. And below the thyroid and the cricoid, we have the cricothyroid membrane, which is here. So you open vertically, and then you open the membrane, and then you insert the tube inside. The other definitive airway we have is the tracheostomy, and the tracheostomy is done in the suprasternal notch, and we open into the trachea. It also has a cuff inflated. Now in the emergency department, the first choice is the endotracheal tube, and if failed, you can put a cric or tracheostomy. Now tracheostomy is on this picture here. You can see that it is done suprasternal, that is inserted in the suprasternal notch. You have to go through the skin and through the subcutaneous tissue and through some muscles and into the trachea. The cric is more preferred to tracheostomy in emergency settings because it is faster to make, and you only open a skin and then you go into the membrane, while in the tracheostomy you have to dissect through some muscles and you might hit a bleeder, while in the cric you go through a thin membrane into the airway. So the tracheostomy takes more time, and it also has more complications. Now tracheostomy can be permanent, while the cric can't be left for more than 72 hours because of the risk of cartilage necrosis due to pressure from the tube. Now the endotracheal tube can't be left for more than 2 weeks because of the risk of a pressure necrosis on the cartilages. Now with that, we reach the end of this video. Thank you guys for watching. Please give us a like, comment your ideas and questions, and subscribe. And if you want to support more, please consider becoming a member of this channel by clicking the join button or by following the link in the description of this video. Thank you for watching, and peace.